All right, so we'll get started with the biportal fusion. I already got things prepped out, and then we'll get started here. Do we have, and then water.
All right, how's it going?
Yeah, it's going.
Okay, and then the sled.
Which one? What exactly what's up there?
Well,
Get focused here. So I already did a laminotomy, and let me point to the relevant anatomy. So this is L3-4 that we're doing. This is the inferior border of the lamina here. You can see ligamentum there. I did my facetectomy already, and the dura would be under this ligament here, right there. And so if I wanted to do a ULBD, I can do that. This is epidural vessel, and then you have your exiting nerve root kind of peeking in right there. I can use my my scope retractor, I think. There it is. And I can retract. And you can, what's nice about this is you can, definitely get tension. I could retract the nerve root. I can, get all sorts of bimanual two-handed work going. And so here's the, get rid of some of this fat here. So again, I wouldn't be doing this in a real person where I'm using the 90 degree at level 9 cutting power in the epidural space. I would use a smaller thing, but since we don't have that here, and the cadaver's not alive. Do we have an annular knife? So when I get to this point, then if I have enough exposure, then I can do my annulotomy.
So Don, for this approach versus the laminectomy that you kind of showed before, I know Greg might talk about it a little bit later. Were your incisions a little bit different while you're doing this annulotomy?
So exactly, yeah. So I like having the working portal incision, the same incision as you would for a pedicle perc screw at L5 or L4. Now I'm at L3-4. And so the caudal pedicle screw, same thing. I like also using the same kind of medial incision for my scopes, like the medial to the pedicle line, because I'm going to use this, like say for a drain. You can instead of making another incision, I already have this incision that I can use for the drain, and then I just make another incision laterally for the pedicle screw of L3. So that's how I like to set things up. So I drew the midline, the medial pedicle line, and the lateral pedicle line. All of it's gone because of the water now. And so the working portal incision is lateral to lateral pedicle line, and then my scope is medial pedicle line. And so that's how I like to do it. But then you can also do the scope in the lateral pedicle line for L3. So you can make that for your pedicle screws later on.
Does that affect your ability to perform a more thorough laminectomy?
Yeah, so I don't know. I like using the medial pedicle line incision because it's very familiar. It's what I do typically.
Mm-hmm.
And so that's why I like you in that. All right, let's take a shot. Can you come on up? Up to the head. Yep. Let's take a shot. Okay. And so this is the disc space X-ray. Yeah, right there. So I'll do my annulotomy, and I probably need to take more. Let me see the kerrison of the bone here. So how I like to do my facetectomy is I'll use a chisel or an osteotome, and I'll sequentially chip off all of the SAP, IAP, and then SAP below that. And then I'll use a kerrison to really kind of get the rest of the bone out. Let's get this sled out.
So Don, how would you describe this? Is it a traditional, like an endoscopic TLIF, transforaminal, more like a PLIF, in between? How would you describe the cage?
This is a traditional TLIF.
Okay.
Sorry, I lost my sled inside the incision.
He needs an endoscope. He needs an endoscope.
Anyways. All right, Kerrison. So I want to really kind of hug the pedicle here, make sure that I have this completely exposed so that I can put the cage in the right trajectory. I don't want the bone to be in my way. So this is traditional TLIF, like you would, where the trans facet, where you take the facet off. So this is the pedicle here. You can feel that there, and then the SAP is off completely. And you can see then I just started the annulotomy. Can I get the knife again? So, and I generally go like right at the just border of the dura, try to leave a cuff of tissue there so it doesn't injure the dura. And then pituitary. All right, let me see the shaver, initial shaver. So this is very familiar. It's like very much like tubular surgery, except without the tubes, which is nice. All right, X-ray. All right, so I'm going to go all the way to the front of the disc space. So that's usually like around a 40, and then I'll start off my discectomy, and this is traditional shaver. Now I can watch this the entire time. Right now I have the ligamentum there to protect me, which is nice. When you're doing a decompression, sometimes you have that open to, I like doing the decompression first. Some people like doing the decompression after this point so that they can have the ligament protect them. So I think just different styles. I'm not feeling much. This is a tall disc, so.
Hey, Don, and do you preferentially do these from the left side then?
Yes. So as a right-handed surgeon, I want to do this on the left side so that I can kind of see normally, as I typically would with all my cases, and be comfortable with what I do. All right, more of a shaver. What size is this one? Do you have what size cage do we have?
12.
This is like the biggest?
Yeah.
Okay. Starting to feel a little contact.
So your standard projections, standard steps are shavers, pituitary, standard disc prep. Is there anything special you do for endoscopic?
No. Just looking at it.
Yeah.
I think that gives me a warm and fuzzy feeling that I can see what I'm doing. I can see the dura, during the entire case. I'm watching this as I go. And then just trying to get as much of the disc out as I can, trying to be efficient with this step. But this is a standard step that you typically would do in a TLIF, except you're doing it under direct visualization with endoscope. And then let me see a Kerrison.
Is the draining on that side? Gotta turn the suction on. Suction is on. Unclipped.
So just continuing to remove as much disc as possible. I want to be able to just put my camera in here. And then let me see a RF probe.
Hey, Don, one quick question that I have. Is there a level, obviously you're lateral to the traversing nerve root here right now, right? Is there a level like, a most rostral level where this becomes really painful because you have to kind of go so, you have to remove so much of the facet joint? So what are the ideal levels, and where do you prefer a transfemoral access, or do you always do this?
I would say, L4-5, L5-S1, 3-4 would be probably the highest level. And then I would actually at 3-4, I would start thinking about doing like an XLIF or something like that instead, and other alternative ways instead of like endo TLIF. But, trying to see like, all right, well, what else could I do to really still accomplish the goals of surgery? But 3-4 is probably the highest I'll go in that.
And one other thing is, I'm noticing that right now the instruments are going in basically
Sure.
unprotected because you have the traversing nerve visualized. Do you ever put the retractor in there and protect it, or is it every pass goes by the traversing nerve root?
I just feel like I know where it is. I can visualize. I don't need to retract it.
Yeah.
And so, I can really just work in this corridor. Sometimes maybe I'll have to retract the dura midline, but usually not. Let me see the RF. So of course I want to be careful with the nerve roots and the dura with this thing in here.
So that's a good point. You said when you're kind of that deep ventrally, you put the burner pretty low. Is same thing with the disc space or not?
Yeah.
Not really. Okay.
I want to be as safe as possible. I don't want the nerve roots to something fell down. Oh, I don't want the nerve roots to get injured if I can help it. So I think the true advantage of endofusion is being able to see what I'm doing as I'm doing the discectomy. And so then that way I can really preserve the end plates as much as possible so I can reduce my risk of subsidence.
Coffee downstairs.
So one of the things I would do is, I would take this like Penfield device or a curette or something like that. And then I would actually just kind of rub it right on the edge of the bone here. And then I would just try to delaminate the cartilaginous end plate and separate it and be able to visualize what I'm doing as I'm doing it. And that gives me a lot of reassurance that I'm not going to be violating the end plates, and I can really kind of visualize the discectomy. All right, pituitary. So, I mean, my OCD can go really nuts right here, and I can just kind of keep going at this and be as vigilant as I can in terms of getting all the disc out as possible. And I have to somehow just stop myself from doing that. It's like, oh, that's that little extra piece. I want to get that. And then, but that's what happens when you can visualize it. You can do a much better discectomy. You can put now big cages. That's why when the Koreans first started doing this, they were putting in large OLIF cages in this space. The X-TLIF approach, which is an extra large kind of approach. And because they're able to really kind of declare out as much of the disc space as possible. So for the interest of time, I'm not going to do all that. But oftentimes I'm looking at the anterior border of the the annulus, and then the ALL will be right next to it. So I think there are times where you could do like annular releases if you want more of that kind of correction. So you can see bone there. And I could do more if I wanted to. So I think we're probably okay. Curette, we'll just do one more pass of the curette, and then we'll put the cage in. So I always back up because I want to see what this thing is doing, my instruments, and you know, I don't want to have a dural tear because of my instruments coming in all the time. So right now I'm in the disc space, and I could probably try to find the annulus. All right, pituitary, one more time. One last time.
Don, you ever do a ALL release?
I have, and you know, it'd be great to have, but I do at the very end, just so I don't want water to go into the retroperitoneal space, and so I worry a little bit about that. So I'll just kind of section it, and then my cage will then kind of pop the rest of it, and then you get all this great lordosis correction.
Do you go through and through, or do you?
No, I thin it out. Do you have the micropituitary?
Yeah, so you let the cage do the finishing work.
Yeah. I thin it out so that I can then, so I don't have to worry too much about it opening with all this water that then flows into the retroperitoneal space. Okay, anyways. So you can see that the end plates are good here. I can do more work up there. Curette, actually. Yep. I really want this cadaver to fuse. All right. Okay. So let's get the sled. So there's a special endoscopic sled that we got, you know, that it helps me to slide down. And I turn so that the handle is facing me, or I mean, away from me. The reason is I can then use the retractor to help me get the cage and retract the dura for me. And so can you hit this in for me? X-ray? Okay, go ahead. So I can watch it go down all the way, X-ray? Okay, keep going. X-ray? Okay, and let's see if I can. Can you pull this back while you hit? Or you could just do that. Yeah, let's do that. So it's a back slap that we could use to remove this, this sled. I think this sled allows you to put in a pretty large cage, which is great. Okay, good. All right, and then let's impact it more. X-ray. Get all the way to the front. So I want this cage to go all the way to the front of the disc space. Good. And then let's go to an AP. So I'll switch it to an AP X-ray real quick. Actually, real quick, lateral. Yeah. That better? Yeah, go ahead. Go to an AP. Now I want it to go, so I'm all the way to the front of the disc space with this, and then I want to go across the midline. So I want to see this in the AP view. And
take away the tilt. That's for
Yeah.
L5, S1.
Right.
L3, 4.
right. Probably don't need this. Can you rotate the, yeah, thanks.
Looks good.
Okay, now we can expand it. X-ray again, real quick. All right, go ahead. So this is going to expand. What's nice about this system is that it's all-in-one inserter. It inserts, it expands medial to lateral. It goes up in height as well. So once this completes its medial lateral expansion, You see there, and then we can then go to let's go to a lateral again. So I want, ideally, pedicle, medial edge of the pedicle to the other medial edge of the pedicle coverage. In an osteoporotic bone with the end plate preparation that we did, where we were able to really visualize it and not violate the end plates as much as possible, that can be helpful. So yeah, impact that in more. I want that, because it shortens as it expands medial to laterally, it backs up oftentimes, and I want it to go forward to the front of the disc space. It's probably fine, right? Can't tell. All right, and then probably a little bit more. Yeah, can you do it more? X-ray? It's not going. Maybe there's some disc or something that's... The back is there? Oh. Can you impact it more then? X-ray? Are you sure? Oh, okay. Oh, I'm looking at this something else, yeah. Okay. All right, so now it's going to expand in height. We got it to the front of the disc space, and then we're going to expand in height all the way. This is good. And this goes what? You said up to 12? This was a 9 to 12? 9 to 12. So it goes up 9 millimeters to 12, and then it goes 10 millimeters to like 21 millimeters in width. So pretty large expansion. X-ray? No. All right, well, looks like it subsided. And then we can then take off the... Okay, we'll take out the inserter parts. We can put in a locking screw so that it can get the screw locked in. And then you can backfill with bone graft this way. You can then do bone graft like this. And then there's a final locking screw. You can then use this so that you know it's not going to collapse down. You don't need to. It was FDA tested without this locking screw. It has a passive locking mechanism to begin with. And then we then remove the whole inserter completely. And then where's the, yeah, water on. Where am I going? Here it is. There it is. So there's a screw. And there's the cage in its final position. Okay. X-ray again? All right. Can you go to an AP? Oh, thank you. I think we're done. All right.
Okay.
So pretty large footprint. We got a medial lateral. It looks like there's some subsidence there. The cadaver, not going to like that, I guess. All right. Thank you very much.